I want to kick off the meeting now by introducing our keynote speaker, Dr. Garry Gold, who is professor and chair in the Department of Radiology. Dr. Gold is an international expert in musculoskeletal MRI. Over the past 25 years, he has made seminal contributions to the field, including the first application of ultra-short echo time imaging to diagnose musculoskeletal disorders. Dr. Gold has received numerous awards, patents, and grant funding for his research, including more than 200 peer-reviewed articles and 400 presentations at national and international meetings. Dr. Gold was the vice chair of research from 2017 to 2020 and worked closely and firsthand with Sam. We are delighted that Dr. Gold has taken the helm as the department chair of radiology. Garry, the floor is all yours.
Thank you so much, Joe. Good morning, everybody. Thank you. I'm truly delighted this morning to give a presentation to you on the future of radiology and integrated diagnostics, specifically what we're doing at Stanford to build on Dr. Gambhir's vision. So I see 5 trends that are influencing the future of radiology and integrated diagnostics. The first being integrated diagnostics itself, the merger of radiology and pathology, the application of artificial intelligence technology to imaging and biomedical data, improved access to imaging, including health equity in underserved populations, the development of wearable technology and home-based monitoring, and then image-guided, minimally invasive therapies. In the realm of integrated diagnostics, pathology and radiology are both dedicated to developing, managing, and communicating diagnostic data to the treating physician. The future merger of these fields into integrated diagnostics is already happening. And we can see an example here in a patient with prostate cancer with registration of the histopathological data with the MRI data. This has continued to accelerate with the proliferation of diagnostic technology, digital imaging, and big data analytics. Artificial intelligence is having a huge impact on the field of radiology and medicine. Connections between computer science, engineering, and radiology will continue to enable AI to improve radiology workflow and accuracy. Here, Andrew Ng and Kristen Yom are working on a model to diagnose cerebral aneurysms from head CTs. Faster and lower cost imaging exams are already here. This is an example of a rapid cardiac MRI with complete structure and function done in 5 minutes in our children's hospital. Lower costs of imaging, increased access, and increased health equity are coming to radiology, and AI will further automate these exams and make them widely available. Here's another example of a fast, low-cost imaging examination, a 1 millimeter isotropic whole brain image in less than 2 minutes using magnetic resonance fingerprinting to get multiple types of image contrast. Now, Sam saw the evolution of wearable and home-based technology and recognized that this will become routine in the monitoring of patient health. This is an example of an activity watch used in the baseline study, the smart toilet system pioneered by Sam's lab, and the vision for precision health laid out in Sam's article in Science Translational Medicine. Minimally invasive treatments are going to be an important part of the future of the field. Here, Paige Ganuni, one of our clinician scientists in the department, is using magnetic resonance guided high intensity focused ultrasound to treat essential tremor. The field of theranostics is connecting our patients to cutting edge treatments using molecular targeting. This is an example from our newly opened theranostic clinic led by Karina Marie Aparici and Andre Garu. This is a patient with a neuroendocrine tumor being treated with Lutathera, which was just recently approved for specifically targeting this disorder. We're going to build on this technology by installing a new solid targetry cyclotron out at the Porter Drive campus. So what is precision health? Well, the Stanford School of Medicine mission is just that, precision health, to predict, prevent, and cure disease precisely. And our goal is to lead the biomedical revolution in precision health. And the department that Sam really designed around this concept is poised to lead the revolution in this area. So what's the difference between precision health and precision medicine? Well, precision medicine is the right treatment at the right time for the right patient. Precision health is very different. It's a fundamental shift to a more proactive and personalized healthcare that really empowers people to lead healthy lives. This requires monitoring and early diagnosis to predict and prevent disease before it strikes, or diagnose and cure it decisively and early if it does. I'd like to play a brief video clip of Sam talking about this concept.
This talk is about my fight to change healthcare through focusing on what we now are calling precision health. It begins with risk assessment at all stages of life, including at the time of conception. I'm convinced that a future that is going to involve precision health will be the right way to approach healthcare and will be fundamental to our changing of how we deal with health and disease today. So in conclusion, it has been a phenomenal journey since 1996, when I was working actually on decision modeling to help get FDG approved as a normal clinical tool. Through the confidence Mike Phelps had in me and other mentors had in me, we would start to move into this whole area of merging cell molecular biology with biomedical imaging. That would lead to an explosion of applications in multiple fields. And now, as I show you where we are in 2018, we are in a whole era where we're shifting medicine from being more proactive instead of reactive. How do we get to the front end of the problem? And it's been an incredible journey. I've been at the Society of Nuclear Medicine since the age of 20. I'm now 55, and this 35 years to me has been a terrific journey. It's been an unplanned journey. I wish I could tell you we knew where we were going. Each year, things lead to the next thing, which leads to the next thing. But the common theme is that we're always venturing into areas that we're not comfortable with, something I learned to do from people like Mike. Things that make me uncomfortable tell me I'm on the right track. You can learn anything as you need to go. I trained as a mathematician and an MD, not as a cell molecular biologist. But I believe now I can tackle almost any area. Late-stage disease should not be our only focus. We have got to stop focusing on disease at the tail end of the problem. Don't just look at cancer scan after cancer scan counting the lesions. Think about what we should be doing on the front end of the problem. How do we prevent, and if not prevent, detect very early disease when we have the best chance of making a difference? I believe to do this, a revolution in precision health is coming, and I believe life is much like our joint journey on a train. We're all put on that train. Our parents are on that train with us, but they leave us. In the case of myself and Aruna, our son left us on the train, but it's the journey that's important. And how we treat each other, the respect we give each other, not only to our direct immediate family, but to all of us, to each other, is how we will be remembered. And that's the most important thing we can do in our life as we look after each other as part of our extension.
So I was fortunate to be on that train with Sam and learn from him. And as many of us on the call here have learned from Sam. So as Sam described, we as a society focus far too heavily on the tail end of the problem, too heavily on illness and not enough on prevention and early detection. Health and disease are a complex interplay of biology, the environment, and many other factors, and characteristics that result in the transition from health to disease are poorly understood at this point. We really need a more profound understanding of the transition of health to disease that allow us to focus on preventive measures and provide opportunities for monitoring and preemptive intervention, which will also inform the development of new treatments. As Sam described, the vision of precision health requires risk assessment at all stages of life, customized monitoring using wearable diagnostic tools, smart home technology, biomarkers, imaging, and implantables will allow us to continuously monitor and surveil people for the earliest signs of disease. Combining this with data analytics using AI and a digital in silico twin of the subject located in the computer will allow for pattern recognition and predictive modeling of disease. And once disease or the risk of disease is identified, early intervention can be performed either through coaching and support, specific testing, or precision medicine. This is the vision of a healthy future, a vision of healthcare rather than sick care that Sam described. If we look at the example of a jet engine as an example of a monitoring or sampling problem for medicine, a jet engine has hundreds of sensors that monitor the engine thousands of times per second. This is continuous monitoring that results in a large stream of data on temperature, pressure, and oil debris analysis that is analyzed using models, AI diagnostics, and big data for signs of failure of the engine. Once the engine indicates signs of failure, it's removed from service and fixed before it's put back into service. If we contrast that to our current approach for healthcare, we get maybe one doctor visit per year where we use relatively crude technology like body temperature and heart rate to screen for disease. This results in missed opportunities for detection and late detection of disease. The revolution in wearable technology is really enabling the possibility of continuous monitoring on the patient where they live. Breath analysis can detect volatile organic compounds and possibly early cancer. Implantable cardiac monitors are already in widespread use. Many of us have a smartwatch which monitors movement and vital signs. Of interest to me, there are smart shoes out there which allow you to detect contact pressure and walking patterns. Contact lenses which can detect pressure in the lens. Smart clothing that can detect vital signs, and electronic skin, which I'll talk about later, which also enables us to measure sweat chemistry and other signs of health and disease. We can extend this to the smart home, where you have all forms of connective devices in the bedroom, in the bathroom, in the kitchen, and in your car, monitoring for the earliest signs of disease, including a Wi-Fi system, which is now being tested to determine how well people are sleeping using reflected RF waves throughout the house. Sam pioneered some of this technology with his development of the smart toilet system. This is present to monitor urine and solid waste for signs of disease, and is a technology that's rapidly improving, led by Sunming Park after Sam left us. Here's a schematic diagram of the smart toilet. This figure is a perspective view of a toilet having a mountable device for continuously measuring baselines of human excreta. This includes a 10-parameter test strip for urine analysis, urine flow, stool classification, and measurement of other factors of wellness. This type of monitoring technology is available and being used in many different areas, including cardiovascular disease, mental health, precision diets, cancer, and improvements of sensors and biomarkers. I'm going to briefly share some of the developments going on at Stanford in the Fine Center, which was founded by Sam. So in cardiovascular health, the first example is the large baseline study, which was led by Sam Gambhir and is a collaboration between Stanford, Duke, and Verily to characterize people across the lifespan to determine what is normal using the most advanced imaging, in vitro, clinical, and molecular tools. This study is ongoing and currently led by Ken Mahaffey and myself here at Stanford. And as Aruna spoke about early this morning, has led to early diagnosis in many patients already. One example of precision health is precision diet to prevent diabetes. This is a fine project that's led by Michael Snyder, Manish Desai, Tracy McLaughlin, Christopher Gardner, and Justin Sonnenberg. The idea here is that early detection and identification of phenotypes and individual responses to different types of diet will allow people to create a customized diet plan that minimizes the risk of developing type 2 diabetes. This project uses a combination of omic technology to measure the microbiome, wearable continuous glucose monitoring, and metabolic phenotyping in human subjects. Combining all this data in AI allows the measurement and prediction of the best diet for a given individual. Patients are enrolled. Their patterns are identified from glucose monitoring. The patterns are classified and tied to their underlying physiology. And then we measure the response to standardized meals to try and identify a fingerprint for each individual patient and determine what the best diet is to improve their cardiometabolic risk. This is from Joe Wu's lab. With the rapid increase in healthcare data sets and the development of deep learning models, deep learning and AI has been utilized in many applications in healthcare. But in order to generalize these models and make them more useful, deep generative modeling, which is the capability to create realistic synthetic data from real data, has been critical for the development and advancement of deep learning and precision health. And Joe's group is testing the impact of these deep generative modeling approaches on these AI models in various aspects of cardiovascular disease. Many of us have undergone medical imaging tests such as CT scans for various reasons, including perhaps trauma if you're in an auto accident. It turns out there's a lot more data present in these images than is captured in the radiology report. And this project, led by Akshay Chandari, really looks at this data in detail, compares it and combines it with data from the electronic health record to model prediction of chronic diseases such as cardiovascular disease and osteoporosis. Sensing and biomarkers is an important area of advancement in precision health. This is from Zhenan Bao, which is a wearable skin-based sensor. And she thinks that it will be possible to create a sensor that will collect whole body data without interfering with the patient's normal everyday activity. Zenon is leading a group of investigators and the eWare Institute to develop more of these flexible biosensors. These flexible sensors can be placed anywhere on the skin or the clothing. They're stretchable and lightweight, and they transmit data to smartphones or other devices. They can be located on many different areas of the skin or on clothing. One area of particular interest is monitoring the sweat. There are many sampling sites of sweat on the skin, and you can continuously access and monitor non-invasive markers. Sweat can be stimulated, as we see here in this example from the Rocky movies, and it contains valuable untapped information on a patient's health condition. Mostly what we get from sweat right now are electrolytes, glucose, lactate, and ethanol. There are many different types of sensors available, different types of tattoos, patches, bands, and Band-Aid types of devices that can be worn and sense these on an ongoing basis. Tom So and his group here at Stanford have developed a molecular tracker for use in the gut. This is a pill that you swallow. Diffusion ports allow metabolic markers to flow into the device, where aptamer-based technology is used to sense changes in electrical current that occur when a metabolite binds to the aptamer and indicates the concentration of that metabolite in the gut. This system would pass through the entire intestinal tract and monitor gut health. One of the really exciting developments around this has been pioneered and led by Joe DeSimone and Sharon Pateri. Joe DeSimone is the Sam Gambhir Professor of Translational Medicine and is an expert in 3D printing, and Sharon Pateri is an expert in protein analysis. They're using 3D printed microneedle technology to monitor the interstitial fluid, which is just beneath the surface of the skin. The interstitial fluid is part of the epidermis, and the microneedle patch shown here has its tips within the interstitial fluid, which has a similar concentration in metabolites to blood plasma. This area also has a high number of immune cells and lacks nerves, so it's not as sensitive as other areas such as the subcutaneous tissue or the intramuscular regions. Joe pioneered this technology for vaccine patches for vaccine administration during the COVID-19 pandemic. Many different types of microneedles can be printed using 3D technology and applied to the skin as a patch. To better understand how the microneedle vaccine would work better than an intramuscular injection, they tested this in mice and found that a microneedle-based approach induced 50 times higher antigen-specific antibody responses than an intramuscular injection. This technology has led to the formation of a new startup spun out of Stanford called Eigen, which involves Vijit Sabonis, Alex Yokohawa, Tom So, and Joe DeSimone as the founders. This uses a combination of the aptamer technology developed in Tom So's lab and the microneedle technology that Joe DeSimone developed as a platform to measure any molecule in the subcutaneous tissue. This will enable us to sense markers of metabolic health such as glucose and cortisol, hydration, and small molecule drug levels throughout the body. As opposed to continuous glucose monitors, which are already on the market, the sensors developed by Eigen will use aptamer technology to sense different specific metabolites, which can be modified on demand. The existing continuous glucose monitors are a one-use, single-use type of approach, whereas Eigen sensors are specific and multiplexed and can be reused, as opposed to the continuous glucose monitors, which are disposed of after a single use. Now I'd like to pivot to mobility and fitness, which is an area that I'm particularly passionate about. This is a project led by Brian Hargraves, Scott Delp, and Akshay Chowdhury out of Radiology in understanding the development of knee osteoarthritis using imaging and biomechanics. So we know that knees wear out. We know that osteoarthritis has about 30 million cases annually in the US. It's a leading cause of disability, and it causes immense pain and suffering across the landscape. We don't really know the causes of osteoarthritis. We just know that pain develops tissues degenerate, and eventually you end up with bone-on-bone disease. The timeline progresses from a healthy joint to sometimes an acute injury, sometimes not, to finally treatment of the disease at a late stage with a total joint replacement. Our vision is to better understand the development of osteoarthritis and monitor the development for early intervention using rapid imaging, portable video, and biomechanical analysis to better characterize the transition of health to disease in arthritis. If we consider a specific knee scan that is done right now in the MRI scanner, this takes about 30 minutes, gets a single knee, and costs over $500. We've developed rapid imaging technology that allow us to scan both knees at the same time, getting alignment, fat water, and quantitative information, including information on cartilage biochemistry from both knees within 5 minutes, which rapidly decreases the cost and increases the access to this technology. Combining this with automated analysis of the cartilage biochemistry allows us to monitor the joint at a low cost at many points in time. Current gait labs require multiple cameras and are very expensive to acquire data on how people walk. We've improved this technology using the smartphone in your the camera in your smartphone to do a video-based gait analysis that allows us to do biomechanical measurements combined with worn devices such as IMUs, which can measure things such as the knee flexion and extension moments. With this, we believe we can teach people to walk differently and decrease their risk of pain or progression of osteoarthritis. And we have some early promising data in this regard. Other types of analysis, including understanding the problem of repetitive head impact. This is a study from Aaron Gibson, Michael Zaney, and David Camarillo involving advanced neuroimaging and histopathology in an animal model, looking at the impact of traumatic brain injury at multiple points in this animal model to better understand the progression of this problem. With the advent of the pandemic, many doctors' visits became virtual. One option for remote monitoring is to use the capability of a smartphone to vibrate to test the tactile sensitivity and the ability of patients to sense vibration. That can lead to new remote monitoring capabilities for those at risk for peripheral neuropathy or peripheral vascular disease, and can facilitate early detection of these problems. Mental health, as we all know, is a huge problem, especially during the pandemic. Ian Gottlieb and his team are using support from the Fine Center to study depression and suicidal behaviors during adolescence. This is of particular interest to me as the father of 3 teenagers. Why should we care about depression? It's the leading cause of disability worldwide. It has a huge worldwide annual cost. And 80% of people who develop major depressive disorder experience recurrent episodes, and it's a significant risk factor for suicide. Adolescence is a particularly important time for increased risk of depression and suicidal behaviors. 25% of adolescents will develop depression, and 60% of adolescent suicide victims have had a depressive disorder. Ian's project is monitoring inflammatory markers in the blood, such as cortisol, using neuroimaging such as structural, functional, and diffusion MRI to study depression in the brain, and combining this with wearable technology to measure sleep and mobility during the day, and a cell phone-based app which checks in with the subject 3 times per day, allowing them to express whether they're feeling sad or developing signs of depression. So these are just some examples of Sam's vision of precision health. The take-home points from Sam's vision are that current healthcare is expensive and focuses too much on late-stage disease treatment. Technology is enabling continuous and non-obtrusive monitoring for early signs of disease. And the developments in AI and data analytics will allow us to find patterns in this rich set of monitoring data. There are many issues that remain to be solved around precision health, including reimbursement and privacy. And I believe that imaging will continue to play a big role in precision health, often used as a secondary test when an early monitoring system picks up signs of disease and we need to verify it or localize it. Sam mentioned that we're all passengers on this train together. I feel incredibly fortunate to have worked with Sam and gotten to know him during my time on the train with him. He left us too early, but his vision for precision health remains and is as vibrant as ever in our research going on at Stanford. Thank you.
So thank you so much, Garry, for this outstanding talk that highlights Sam's vision and also the exciting research that are being done by you and also by the different faculty members within radiology and other departments at Stanford. So we'll open this session for discussion right now. And perhaps I can start by asking you a couple questions. The first question I have is, you mentioned several examples of precision health. And I think, as you know, for medical testing, the sensitivity and specificity are important to avoid false positive and false negative. And so my question is, are there going to be a lot of false positive and false negative from these continuous screening and continuous monitoring?
Yeah, thank you, Joe. That's a great question. I think if you know about the technology currently involved in screening, you need a high sensitivity, which often results in a large number of false positives. The advantage of continuous monitoring is it allows you to continuously check to see if what you're looking at is an ongoing problem or simply the result of a one-time noisy data point, for example. In addition, I really believe that low cost and easy access imaging will be crucial in checking and localizing any abnormalities that occur based on these blood-based or wearable technologies that people will be monitored with. So yes, there will be false positives, but we will have the tools to manage those and confirm whether they're truly real or not.
Mm-hmm. Got it. Okay. And then I also encourage the audience to put your questions on the Slido chat box, and so that I can read off them. And so maybe I guess as a follow-up question then is, this is a lot of testing, and so how do we pay for it, and who's going to pay for it? Yeah.
Yeah, that's a great question, Joe. Sam would often talk at the opening of our new hospital at Stanford, which is behind you in your background there, that, boy, this is a fantastic facility, but in the future, we hope we're closing these because we no longer need them. The shift to precision health really requires a paradigm shift in the way we think about and pay for healthcare. Capitated systems like the Kaiser system, for example, are inherently incentivized to use precision health to lower their system costs. But our current healthcare environment, which pays for procedures when people are sick, is certainly not incentivized to transition to precision health. So there's a lot of work that needs to happen for us to get to a point where we recognize the value of precision health and we spend the appropriate amount of resources on keeping people healthy as opposed to, as Sam said, focusing on the tail end of the problem.
Mm-hmm. Yeah. So I just saw the question by Dr. Mahesh from Johns Hopkins, and his question is, how is it, how the health inequity that currently exists in the US? I think he kind of commented on that with your questions. As I scroll through these comments, maybe let me just ask you another follow-up question that I have. What about the privacy concerns that may exist with these continuous monitoring? What happens if somebody hack into the system, online system?
Yeah, no, it's a great question. And like many areas of our society, financial, healthcare, legal, privacy concerns are going to be a significant question here. And we also want to make sure that patients' risk for certain diseases is not used against them by insurers or other people in the marketplace who may use that to enhance their risk pool, for example. Again, this is an area that requires a lot of work, a lot of government action, I believe, and a lot of regulation to ensure that people feel comfortable sharing this data with their physician and with their healthcare system. It also requires that patients see the benefits of sharing this data in terms of improved health and early diagnosis, such as what Aruna described happened to her in the baseline study.
Mm-hmm. Mm-hmm. Got it. And I guess I have a question from the audience, and this is pertinent to my field. Where is fMRI in relationship or the update in cardiovascular imaging?
Boy, that's a great question, Joe. There have been studies, I believe, that try to correlate fMRI activity with brain activation after cardiovascular interventions, such as coronary artery bypass disease. But I think the links between cardiovascular disease and neural disease are still being explored. So I think it's an important area to look at. We know that increasing blood flow to the brain is very important, and activity is also very important in maintaining neural health. So I suspect once we start looking, we're going to find more and more linkages between cardiovascular disease and neuroscience.
Okay, so thank you, Gary, so much for your keynote talk. It certainly carries on, Sam's legacy as well as lay out the vision that you have for our Department of Radiology. Thank you so much again.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.